Morning, Doctor. Professor, sorry.
So today we are talking about disorders of the orbits and eyelids and the orbit. Welcome to the lecture on the eyelids and orbit. The eyelids cover and protect the eye from various types of injuries, including mechanical trauma and desiccation. It is important to be familiar with the various types of eyelid conditions because they are very common and may lead to facial disfigurement. Don't be surprised when patients come complaining about tiny cysts around the eyelids, because as you know, the eyes is what one sees most when you meet someone. So if there are small things around the eyes, they are very easy and noticeable, and people get concerned about them. Even if you yourself are not concerned, your friends and neighbors may draw your attention to them and need them to be corrected. Now, the orbit is the body cave in which the eyeball is housed and protected. It can be affected by various conditions, most of which manifest by protrusion of the eye, a condition known as proptosis. This is because the bony walls of the orbit are inelastic. So conditions that are accompanied by increase in size tend to push the eye out of the orbit. The direction in which the eyeball is displaced usually gives a clue as to where the lesion is found and what type of lesion it's likely to be. By the end of this lecture, you should be able to describe the anatomy of the eyelids and the orbit, describe the common disorders of the eyelids and their management strategies, and describe the common disorders of the orbit and their management strategies. Now, for this lecture, I have borrowed some of the lectures that I have been exposed to. I thought for the benefit of giving you a lot of content, these ones could give us a lot, and I'm going to share this with you so you'll be able to go through them in details or at your own pace when you are ready. So I am sharing them. As they are. Let's first look at the lecture by Dr. Alexis. Alexis was one of our students whom we asked to prepare a lecture on this topic, disorders of the eyelids. And I thought that was a good one, so we can have it. Just Some of the things that I'm going to talk about in this lecture are brief anatomy of the eyelid, then eyelid malpositions, and eyelid inflammations, and various lesions on the eyelids. Just to remind ourselves, the eyelids, the layers of the eyelids are 7. From the outside, the skin and subcutaneous tissue. And remember, the skin of the eyelids is very thin, basically no fat within the subcutaneous tissue. Then there are muscles of protraction and muscles of retraction. Then there is orbital septum, orbital fat, the tarsus, and the conjunctiva. As you can see, we'll see in the diagram later on. The skin is the subcutaneous tissue. And it is the pretarsal skin is that skin which is in front of the tarsal plate. And the pretarsal skin is that preceptor skin is that which is up or below the tarsus, where it covers the orbital septum. And the eyelids, there is an eyelid crease which marks the attachment of the levator aponeurosis to the pretarsal obturalis bundle and the skin. The orbital septum fills with the levator aponeurosis. The protractors is mainly the orbituralis oculi muscle, which is innervated by the cranial nerve 7. And it is responsible for closing the eyes or for winking. Just a diagram showing the different parts of the orbituralis muscle. You can see it is surrounding the eye and has got different components, which we don't have to go through at this time. Then there's the orbital septum. This is the orbital fibrous tissue, which arises from the periosteum of the orbital bony margin. And as I was already mentioned, it fills with the levator aponeurosis. The levator is the muscle which raises the eyelid. And the capsulopalpebral orbital septum, that is the fibrous kind of diaphragm, which is in front of the orbit, and various structures attached to it. Then going into the orbit is the orbital fat, which is posterior to the orbital septum. The retractors are those which open the eye. And the main one is the levator muscle, or the levator palpebral superioris. And it arises from the apex of the orbit and raises the upper lid. It is a striated muscle. Now, beneath it is the Murray's muscle, which is an involuntary muscle, which is innervated by the sympathetic system. And in the lower lid, the equivalent is the capsulopalpebral fascia and the inferior tarsal muscle, which are less prominent, but nevertheless they are there. The levator muscle is supplied by the superior division of the cranial nerve 3, that is the oculomotor nerve. I've already mentioned that Murray's muscle is involuntary and is innervated by the sympathetic nerves. This one, let us skip it. This for now. Different figures, which we will talk about when it comes to ptosis. Let's skip this now. The tarsal plate or the tarsus is a very important structure. It consists of dense connective tissue. It forms the skeleton of the eyelid. The upper eyelid, in the upper eyelid, is larger and it is about 10-12 millimeters vertically. And the lower eyelid, about 4 millimeters vertically. About 1 millimeter thick, and the upper lid is about 25 millimeters long. It is shorter and smaller in the lower lid. This one is a diagram showing a cross-section through the eyelids. I think I'll go through this when I go to the other lecture, which shows them in a more magnified detail. The eyelid is lined on the posterior aspect by conjunctiva, the tarsal conjunctiva, which is a non-keratinizing squamous epithelium, and has got some of those accessory lacrimal glands. As I said earlier, the main function of the eyelid is protection. It offers mechanical protection to the anterior globe. It spreads the tear film over the conjunctiva and the cornea with each blink. It contains the Meibomian gland, the Meibomian glands. These are parallel glands within the eyelid, within the tarsal plate, and they have their openings at the eyelid margin. And the Meibomian glands produce some oil, which provides the lipid component of the tear film. Now, this is very important. If a person is unable to close his eyes, they are likely to lose their sight because the eye is designed to work in a moist environment. So if it dries up, then the loses function, especially the cornea can ulcerate and perforate, and the person becomes blind. Also, the eyelids contain puncta through which the tears flow into the lacrimal drainage system. I think we talked about the lacrimal drainage system last time, didn't we? So you should still be able to remember this. So one of the common problems of the eyelids is when the eyelids are not able, or the upper lid droops, a condition known as blepharoptosis, and commonly abbreviated as ptosis. I will not go through the details now. I'll let you go through the details yourself. There are different factors, the mechanical factors, neurological factors, myogenic factors. Myogenic means having to do with the muscles. And in the environment, myasthenia gravis is quite common. So you need to take particular note. Some of these others you might not see all that often, but this myasthenia gravis are among the myogenic droop it's a cosmetic blemish. But if the eyelids are droop enough, they may obscure the visual axis. So the patient may not be able to see clearly. In order to see, sometimes you see people lifting their chins so as to see under their drooping eyelid. Now, in babies and young children, it is important to make sure that the visual axis is not obscured, because if the visual axis is obscured, it may predispose the condition known as amblyopia. The retina will not develop properly, so that in later years, even if the condition is corrected, the amblyopia may only be permanent. These are some of the figures some of the parameters that we measure when we are evaluating a patient with ptosis. The margin reflex distance, MRD, is the distance when you shine a torch between the reflection of the torch and the lid margin. And when it is low, when it is ptosis, then that one is diminished. I think for now I will not bother you with these figures, but you should look at them and memorize some of the important ones. There are various causes of ptosis, possible causes of ptosis. So in the management, it is important to exclude the underlying causes which could resolve the problem. For example, as I said, in myasthenia gravis, you need some medical treatment. But in most cases of ptosis, if they have to be treated, they are treated surgically. And there are various procedures for correcting ptosis. Now, in very young children, it's usually deferred but may be expedited if the pupil is covered and threatens to induce amblyopia, as we have already mentioned. One of the commonest methods we use for correcting ptosis is what we call the frontalis sling. Sometimes we also we call it brow suspension. A piece of string is inserted beneath the obturalis muscle and lifts the eyelid up. It's called frontalis suspension. The other common problem is entropion. This is an inturning of the lid margin. In the elder, it is mainly the lower lid which is affected. But in our setup, we are more likely to meet that of the upper lid, which is maybe due to scarring as a complication of trachoma. So take some time to go through all these causes. Here is an example of an inturned lower lid margin, usually in the elderly, when the eyelids become kind of lax. So the eyelid may turn inwards or outwards, as we shall see later. So this is lower lid entropion. Ectropion is eversion of the lid away from the globe. And as I have already said, it can occur in old age. In old age, it can either be entropion or ectropion. This is an example of the ectropion. You can see that the lower lid is pulled away from the globe. And you can see the punctum here is everted. So the tears will not be able to enter this punctum. So the patient may complain of a watering eye because there is overflow. And the watering eye may be for another reason, in that the eye may not be completely covered. And when it is irritated by dryness, there's a reflex production of tears. The other problem is blepharitis. Blepharitis is inflammation of the eyelid margin. There are various types and various causes. Please take some time to go through them. Here's an example of blepharitis. So the picture is not very clear, but you can see there are crusts around. We are going to see better pictures later on. The different types of blepharitis, anterior and posterior. We'll be able to go through the signs. So another case of blepharitis, you can see the eyelashes are matted together. And some of these eyelashes may fall off. You'll be able to read through the treatment. Another common condition is corrosion. Now, a corrosion is a granuloma within the tarsal plate caused by obstruction of the Mbarara gland. It is painless. The symptom is a lid swelling, which usually resolves within 6 months if not surgically removed. This one needs to be differentiated from a hodioram or sty, which is painful. I hope you remember the characteristics of a granuloma. The histological features of a granuloma: giant cells, lymphocytes. You guys, I think you remember it better than me. Granulomatous inflammation. This is an example of a corrosion, a large corrosion. Then internal hodioram is inflammation of the Mbarara gland. The same gland that can be affected by corrosion, but the internal hodioram is an acute inflammatory lesion, which forms an abscess within the Mbarara gland, and it is painful. It may respond to topical systemic antibiotics, but incision may be necessary. Now, if you need to incise this lesion, the internal hodioram, the incision is made on the conjunctival side. The incision is made on the conjunctival side as opposed to an external hodiogram, which I was just about to see, where if you have to incise and drain, the incision is made on the skin side and it is horizontal parallel to the lid margin. But it also illustrates an internal hodiogram. Now, the external hodiogram is the more common of the things I've just talked about. It is an abscess in the eyelash follicle. It is also painful. Most cases are self-limiting, and treatment here usually requires removal of the associated eyelash and application of hot compresses. However, if it is a large one, it might require incision and drainage. And as I've already said, the incision is horizontal, parallel to the eyelid margin. So an example of a small sty or a small external hodiogram. You can see that it shows that it has formed pus. And if you pull out this eyelash, usually the pus will drain out. Then there are various other lesions which you can see on the eyelids. One of them is Malascan Contagiosum. This is a viral infection of the skin caused by epox virus. The main feature of the Malascan Contagiosum is the umbilication. It's got a kind of depression at the top, which is plugged by some yellowish whitish material. The treatment is usually opening having understand the patient. You open the crater at the top and squeeze the lesion, squeeze out the white material, and apply antiseptic solution like povidone iodine. Yeah, that's an example of Malascan Contagiosum. Then the other various lesions like xanthelasma. These are the lipid-containing lesions, like those. They usually occur in people who have got hyperlipidemia. So if you see someone with this, then suspect or rule out hyperlipidemia. There's something like actinic keratosis, squamous cell papilloma, like those ones. Basal cell papilloma, keratoacanthoma, those. Apologies for not being able to get pictures of the people you're more likely to see if you practice in Africa. Neurofibroma. So now these are malignant tumors. The commonest malignant tumor of the eyelids is basal cell carcinoma. However, it is more common in the lighter skinned races. So here in Mbarara in Uganda, we're not likely to see many. But it's important for you to be familiar with it because some of you may go to practice outside Africa. So please be familiar with it. There are some examples. The basal cell carcinoma is also known as a rodent ulcer. You know examples of a rodent? Like a rabbit or a rat. The way it eats by gnawing, it just nibbles. So this one keeps nibbling the eyelid. By the way, they are not limited to the eyelids, they're limited to the skin, especially the exposed skin, because sunshine is ultraviolet light is one of the triggers. So it keeps eating locally. It rarely metastasizes to distant sites. Unlike squamous cell carcinoma, which can spread the lymph nodes and other places, this one usually eats locally. A squamous cell carcinoma can occur. Actually, in our setup, it might be more common. Squamous cell carcinoma on the eyelids might be more common than basal cell carcinoma. Those examples of squamous cell carcinoma. Sebaceous gland carcinoma can also occur, but it's rare. It's an example. Merkel cell carcinoma is even more rare and very elderly. It's an example of the Merkel cell carcinoma. Melanoma can also appear, especially it may develop from annulus. This one may initially present as annulus, but later on it may undergo malignant change. Then there are various cysts. These are just small cysts around the eyelids, which may contain some either clear or milky fluid. They're the ones I was telling you about, that people will come complaining about them. They are fairly harmless, except that they are a cause of concern because of distorting the appearance. Cyst of Moore, hydrocystoma, epidermoid cyst. So this is a brief or a rapid scanning through some of the common conditions of the eyelid. There's another lecture on the same topic, which I have also borrowed, and I got from the internet. It also gives you more or less what we have already gone through, but with different emphasis. In particular, this one does not talk about ptosis. I want to do it for this particular diagram, which illustrates the structure of the eyelid. Here, from outside, you have the skin with very thin subcutaneous tissue. Then there is the orbicularis oculi muscle, which is lying over the septum and also over the tarsal plate.
Professor, you're not sharing the screen.
Oh, I beg your pardon.
You are not sharing the screen.
Let me. Oh dear. I beg your pardon. I hope you can now see my screen. Can you?
Yes.
Good. So I was saying that this is illustrating the structure of the eyelid. Skin anteriorly, very thin subcutaneous tissue, then orbicularis ocular muscle, with the levator palpebral superius tendon coming and splits up. Some of it attaches the skin, and some of it the anterior part surface of the tarsal plate. Now, within the tarsal plate are the Meibomian glands, and they open at the eyelid margin, and they pour out an oily secretion. Also, around the eyelid margin, they are what they call glands of Moore. They are modified sweat glands, and also glands of Cysts, which are around the eye bases of the eyelid margin of the eyelids. They are also another modified sweat gland. All these produce oil excretion, which contributes to the precorneal tear film, which you talked about when you're talking about the lacrimal system. Now the inflammations, again, you can see more pictures of blepharitis, different variety of blepharitis, different variety of blepharitis. Then the lid lumps, we're just going through. You've already seen that picture, it's common. The internal hodioram, you can see here, it gives the impression on the inner side of the eyelid here. And if you have to do surgery, you incise from this side. Again, I guess I think this might be more of a Calazion than internal hodioram, because you can see it's hardly any inflammation. Because internal hodioram is an acute inflammation, usually causes redness. About the Calazion, which is where there is no inflammation around. Sometimes it may rupture and cause a granuloma on the conjunctival side. Yeah, this is an illustration of the procedure for the treatment of a Calazion, usually under local anesthesia. There's this Calazion clamp which you apply on the eyelid. It has got a bolt for tightening it. Then you use it to invert the eyelid, and you incise at right angles the eyelid margin. Incise at the right angles the eyelid margin. Then we went through the different positions of the eyelid, Entropion, different causes. Ectropion, inversion of the eyelid, different causes and treatment. So that's it for the eyelid. Let's spend the next few minutes looking at the orbit. Let me find my slide on the I confess I also borrowed this one from the internet. I couldn't remember the original author, but I thought it presents what I could have given to you. Just to remind ourselves about the anatomy of the orbit. And when you're thinking about the anatomy of the orbit, you think about the walls, the orbital apex, the different openings, the different spaces in the orbit, and the relations to the orbit, and blood and nerve supply. The dimensions, the orbit is about 40 millimeters deep. The opening is rectangular rather than square. It is wider in the width, 40 millimeters, and height about 35 millimeters. The different bones of the orbit. I think you can find a better diagram. But with the optic foramen at the posterior, and then these are different bones that make up the orbit. The ethmoid, it's ethmoid, not ethmoid. Ethmoid, nasally toward the nasal side. Superior, there is the frontal bone. Then laterally, there is the, towards the posterior, there is the sphenoid bone. You've got the greater wing and the lesser wing. Then here, there is the maxillary. And a very tiny portion of the floor, there is the palatine bone. Then there's a lacrimal bone. There's a zygomatic bone on the temporal side. So these form a kind of bone cave. It is important to think about the apex of the orbit, where structures enter the orbit or leave the orbit through. And also the extraocular muscles, most of the extraocular muscles arise from the apex of the orbit. And there is a tendinous ring from which most of the extraocular muscles arise and they come forward. It surrounds the optic nerve and the ophthalmic artery. Then there are these various other cranial nerves which are entering And we often ask people to distinguish between those who enter through within the tendinous ring or those outside the tendinous ring. We also have the superior orbital fissure and the inferior orbital fissure. And some of the structures also, and some of the structures enter through these fissures or live through these fissures. So there are different walls, the roof, the medial wall, lateral wall. Then talked about the tendinous ring, annulus of Zinn. The optic canal mentioned as superior orbital fissure. The different openings and what goes through them. The spaces. And these spaces are important to know, especially when you're talking about surgery for the orbit. And also when you're thinking about proptosis. The subperiosteal space is a potential space between the bone orbit and the periosteum that surrounds the orbit. And sometimes there can be accumulation of blood or pus in that space, causing proptosis or when there are inflammatory changes. Then the peripheral orbital space is the space between the periosteum and what we call the cone. There is a cone which is formed by the extraocular muscles and a fascia sheath between the extraocular muscles. Then the central space is a space within the cone, and that central space contains the optic nerve and fat. Then tenon space is a space between the sclera and the fascia layer called the tenon capsule, which surrounds the eyeball. So different accumulations can take place in some of these spaces, or different growths can take place in these places, and they cause proptosis. When a lesion is within the central space or what we call the intracorneal space, usually proptosis is what we call axial. The eye bulges straightforwards. Whereas if the lesion or the mass is in the peripheral space, the eye is displaced out, but may be either downwards or laterally, rarely superiorly. But most times the eye is displaced out and down, forward and down and laterally, or forward, down, and medially, depending upon where the lesion is found. Then when you think about the relations of the orbit, you have to think of the sinuses, the bones around the orbit. Some of them have got air cavities known as the sinuses. I'm sure you have been introduced to them in ENT. And problems in the sinuses can also affect the orbit. Like infections can, if there is the infection in the sinuses, it can spread the orbit and cause orbitoceritis. Also, when they are filled with fluid and they form a mucocele, can also bulge into the orbit and cause the eye to be displaced. It is a spelling of ethmoid, is ethmoid without a here. So please apologize for that spelling error. Now, most of the problems in the orbit manifest as proptosis. That is forward displacement of the eyeball. And there may be endocrinal like exophthalmos. Exophthalmos is a proptosis due to or secondary to thyroid eye disease. Now, ophthalmos is when the eye, instead of bulging forward, it sinks into the orbit. Like when there is a fracture of the bony wall and the eye orbital contents collapse into the maxillary sinus, for example, then the eye there might be enophthalmos. It's the opposite of proptosis. Pseudoproptosis is an impression of proptosis when actually the eye itself is not really displaced. Like when there is myopia, the eye is very big. It may give the impression as if the eye is bulging, actually the eye is just enlarged. Or when the pass of the extraocular muscles, again, the eye may seem to be popping out. And also some obese people, sometimes the eye can appear to be bulging. And in thyroid eye disease, there is eye retraction. Eyelid retraction through the stimulation of molars muscle, the sympathetic muscle, and it causes the eyelids to retract, and the patient has got a staring look. So you have to distinguish whether is it really is it the eyelid which is moved backwards or the eyeball which has bulged forward. So an example of proptosis, this is a rare example in that, well, maybe it's not so rare. You can see this one is not axial proptosis. If you draw a horizontal line through this eye, you can see that it will cut the other eye above. The eye has moved downwards. The eyeball has been pushed downwards. There's also chemosis, that's the mud of the conjunctiva. So it means that there's an inflammatory component, or the conjunctiva may be swollen because of being exposed and inflamed. Same patient. Maybe different causes of proptosis according to the age groups. Although there may be some overlap, but when you're thinking of proptosis and the causes in the children, dermoid cysts, capillary hemangioma, optic nerve glioma, rhabdomyosarcoma. These are some of the common ones. Then some leukemias also. Then there may be metastatic tumors. The neuroblastoma comes from around the kidneys. Then plexiform neurofibromatosis and lymphomas. Of these, probably optic nerve glioma and capillary hemangioma might be the commonest. This is a late retinoblastoma. This one starts in the eyeball itself, then spreads to the orbit, and you can see it has pushed the eye out, and because of exposure, the eye has dried and has become very messy. In adults, there can be metastases from the breast among females and from the lungs among males, but it can come from anywhere in the body. can be cavernous hemangiomas. I think of all these, I've seen more of mucoceles in the bulging. But actually I've seen them in young people recently. They tend to involve both the cranial cavity and may spread to the orbit or the other way around. So they tend to involve not just the orbit, but the cranial cavity. We talked about types of ptosis, and just to help you when you are trying to figure out what could be the cause under different situations, depending upon how the ptosis is manifesting. If there are extracorneal lesions, intracorneal lesions, and those lesions are muscular disorders. We won't have some time to go through all these. You're going to have time to read them. Ophthalmology is also quite common, especially in children, and is commonly secondary to sinusitis. Ophthalmology can be complicated by development of cavernous sinus thrombosis. I hope you remember where the cavernous sinus is found, just posterior to the orbit, and many of the structures that come to the orbit go through the cavernous sinus. So inflammation in the orbit can spread through the veins into the cavernous sinus, which is a life-threatening condition. Exophthalmos, we've already mentioned that it is secondary to thyroid eye disease. Now, thyroid eye disease may occur with or without hyperthyroidism. In fact, can also occur with hypothyroidism. So it is called thyroid eye disease, but often it is accompanied by hyperthyroidism, sometimes no hyperthyroidism, and others hypothyroidism instead. So there are the different facts that you need to know about it. Here's a summary of the signs: Graves' disease. If you like grading, this no specs helps you to remember the different signs. No specs is an acronym for no signs, only sign is lid retraction, soft tissue involvement, manifested usually by chemosis, then proptosis, then extraocular muscle involvement, and corneal involvement, and sight loss. Sight loss can be due to the cornea or the optic nerve being inflamed or compressed. I think this is the last one. So I've taken you through this rapidly because I'm going to share them with you. So soon after this, I'll forward them to Janet, who will be able to share them with you. In the past, we attempted to put them on the online management online learning platform, but looks like it wasn't straightforward for you people to log in. I also tried to share them on Google Drive, but we thought that probably sending it by email may be the most straightforward for you. So I'm going to send them to Janet, who will be able to pass them on to you. Any quick questions? If you have got a question, unmute yourself and or a comment.
Excuse me, doctor.
Yes.
Hello? Yes,
Yes.
I'm asking, is it complicated to give a high dose corticosteroids in exophthalmos in the treatment management?
Yeah, that is one of the options when there is a lot of inflammation and there's a lot of proptosis with the strengthening site. That's one of the options. But I must say that as a general practitioner, which we are going to be in 2 years' time, your role will be to identify and refer. In fact,
Okay.
we tend to manage it with the physicians. We manage the eye complications, and they manage the drug management. They take care of the drug management because they are more familiar with the playing around with these drugs, steroids and thyroid drugs.
Okay.
Another comment? Okay. So I'm sorry that we have had to go through it very fast, but that's the time available to us. But I'm going to send this to you. If you still have any other comments, you can email your comments or questions. Janet has got my email address. Shall we call it a day?
Yes, Professor. Thank you for the lecture.
Okay, welcome. Have a good day. We meet again next Wednesday.
Okay, Professor.
For the last lecture.
Okay.
Same time, same place.
Okay. Have a good day.